Good afternoon. I'm Mark Crowther, and I'm presenting today from the 2016 American Society of Hematology meeting held in San Diego, California. Today I'm presenting the results of our various analyses on reversing direct oral anticoagulants, and I'm presenting on behalf of many individuals who've participated in the various projects that I'm going to be talking about today. It's important to note that I have conflicts of interest to report with respect to this presentation. In particular, I'm a paid consultant with Portola, the manufacturer of Andexanet, and I have a variety of other pharmaceutical relationships which are reported on the slide. Reversal agents are generally not approved for specific indications, and with the exception of Idarucizumab, everything I discuss today will be off-label. Very important in this domain is to understand that there is never going to be high-quality evidence to guide therapy of patients with bleeding taking anticoagulants. This is because it is very difficult to do randomized controlled trials, and outside of a couple of small studies done in patients receiving warfarin, I don't anticipate seeing really good quality data. So our analyses and our recommendations are going to be based on lower quality data, predominantly case series and small prospective cohort studies. Firstly, with respect to non-specific reversal agents, we have the prothrombin complex concentrates. There's very little evidence to support the use of prothrombin complex concentrates in patients with bleeding associated with the use of direct oral anticoagulants. We do have one paper within which volunteers were dosed with a single dose of edoxaban and then received a dose of prothrombin complex concentrate to see what this did to the anticoagulant effect. As indicated on this slide, this was a single-center, double-blind, randomized, placebo-controlled trial. It was a two-way crossover enrolling 110 subjects. Subjects received placebo, 10, 25, or 50 units per kilogram of prothrombin complex concentrate. The graph demonstrates the primary results of this study. On the right-hand side, we have the 10 units per kilogram dosing, which, as you can see, failed to restore hemostasis in any of the volunteers when subjected to punch biopsy. Similar results were obtained with the 25 unit per kilo. With the 50 unit per kilo, we see a normalization of the bleeding parameters, and although these results were not statistically significant, it does suggest that 50 units per kilo of PCC may be an effective strategy to ameliorate the bleeding risk associated with the direct oral anticoagulant edoxaban. However, it's important to note these results were not statistically significant and were seen in a highly contrived model. There's very little data to support their use in actual real-world bleeding patients. Another agent which is widely used or considered is activated prothrombin complex concentrate, or FIBA. Data to support this comes from a highly contrived pig model of polytrauma, and I won't go into detail to explain this to you, but I would refer you to the paper if you need additional information. Suffice it to say that in this model, only pigs who received a 50 unit per kilogram dose of activated prothrombin complex concentrate, or FIBA, were able to survive to the end of the experimental model, suggesting again that this agent may be useful in patients with major or life-threatening bleeding. However, this really again is limited to an animal model. There's very little human clinical data. Moving on quickly to tailored reversal agents, we're now entering the era of tailored reversal agents. Idarucizumab is a specific reversal agent for dabigatran and the first specific reversal agent approved. I won't go into details, I'll just mention this paper which was published in the New England Journal back in 2015, where they took a group of patients requiring urgent surgery or who had major or life-threatening bleeding who were presumed to be taking dabigatran and were given a single 2-infusion bolus of Idarucizumab for a total of 5 grams. As you can see in the graph, the 5-gram bolus of Idarucizumab resulted in complete and nearly instantaneous correction of the anticoagulant effect, which continued out for approximately 24 hours. As a result of this, there's a great deal of confidence that Idarucizumab, which has been approved in the United States and most other jurisdictions, is an effective reversal agent for dabigatran. Andexanet is a specific reversal agent for both the direct and indirect factor Xa inhibitors that's currently under development. Andexanet is very similar to the Idarucizumab insofar as it's a specific reversal agent, but it has a very different mechanism of action and origin. Andexanet alpha is a product in which native factor Xa has been chemically modified to remove the GLA domain and the active site. As a result of this, it cannot participate in coagulation, but it does bind to and inactivate the direct factor Xa inhibitors as well as the indirect factor Xa inhibitors with high specificity. We've presented these results in a number of different sessions for a number of different anticoagulants. This is the results published in our New England Journal paper about a year ago. Essentially what we show on this slide is that when compared with infusion of a placebo, either a bolus or a bolus followed by an infusion of Andexanet results in almost complete and sustained reversal of the anticoagulant effect of the 10A inhibitor. So if patients are going to be undergoing, for example, a surgical procedure where they require prolonged reversal, you would consider giving this drug as a bolus followed by an infusion. If they just require a point reversal, for example, for a time-limited interventional procedure that would be short, you can give the product as a bolus. We reported in the summer of 2016 as a result of our prospective cohort study of the use of Andexanet in actively bleeding patients. This was a multi-center, open-label, single-group study that has enrolled 67 patients at the time of reporting. We evaluated changes in anti-factor 10A levels as well as a subjective assessment of bleeding efficacy. The summary for the results of that study and the Andexanet development program in total are that Andexanet is a specific short half-life agent that binds to and inactivates a variety of 10A inhibiting anticoagulants. It's administered as a bolus or a bolus plus infusion. When given to actively bleeding patients, it results in subjective improvement in bleeding in the vast majority of patients, and it does not change the underlying pharmacokinetics of the anticoagulant, so extended exposure to Andexanet may be required in selected patients with ongoing risk factors for bleeding or needing prolonged surgery. Thank you for your attention.